up some of those questions on that worksheet that we can go through together, 3 or 4 of them or something like that, just to make sure everybody understands that. And again, if that takes up a lot of time, then I'll push the IV access back to next week and throw it in with pharmacology, because it's really not anything pertinent that you guys don't know and you haven't learned in skills lab, to be honest, at this point. It's basically telling you how to start an IV and things like that. Medication math is the thing that trips people up the most. It is the thing that people get most nervous about in paramedic school, is because it's math. I'm not good at math. Med math is very simple, and I'm going to show you guys easy and simple ways to kind of break it down. So I'm going to see if I can pull up a couple different pictures of meds here. Let me see if I can actually download that off Canvas. We'll go through, we'll look at the first one. Bear with me as it downloads. All right, so while that's downloading, I'm going to pull up a whiteboard on my screen. That way I can draw a little bit. And if you guys would just let me know that you can see this once it gets pulled up, so that way I don't have to be just talking for no reason. You can actually see what I'm drawing. Can you see those old scribbles on there by chance? Perfect.
Yeah, we can see them.
Perfect. Now you guys should, I have this turned on, so if you have some touch screen or something like that, you can also draw it on it as well, and I'll be able to see what you're drawing, just in case you need verification or need a little bit of guidance on something. But the first thing I'm going to kind of throw at you guys is how to break down a medication into our concentration. When we mention the word concentration, what we're doing is we're trying to find out how many parts of medication are in 1 ml of fluid. How we abbreviate that would be, let's just say, for an example, 3 milligrams in 1 ml. You can put 1, but when you don't have a 1 and you just put ml, that signifies that it's 1 ml alone. So in that vial, I could have 5 mLs, but I have a constant of 3 per ml. So if I was to draw a vial here, not the prettiest by any means. We'll say this is Zofran. Zofran is supplied 4 milligrams into mLs. Should draw a little bit smaller. 4 milligrams in 2 mLs. That is how much is in that whole vial of medication. So if I was to drop everything in there, I would only have 2 mLs. Now, if I need to figure out the concentration of that med, there's technically a formula that I can use, and that formula is what I'm going to draw here. And it's important to know what this formula is. So the DD stands for desired dose. That's how much I want to give the patient. AD stands for available dose. That's how much is available for me to draw up. Now remember, dose and volume are two different things. Dose is referring to a med. Volume is just referring to a fluid. So it'd be desired dose over available dose times available volume. So if I was to want to give 2 milligrams of Zofran to this patient, that is my desired dose. So I would go 2 milligrams. How much is available? Well, if I look back over here, I have what? 4 milligrams available. So 2 milligrams over 4 milligrams times how much volume do I have available? If I was to draw an arrow, I've got 2 mLs. So times 2. So can anybody do quick math and tell me what 2 divided by 4 is?
Half.
Yeah, 0.5, right? So 0.5 times 2 equals 1. So if I want to give this 2 milligrams, I need to give 1 ml. Now, again, that's the long formula for it. Now, me personally, in my opinion, whatever that's worth, if I was going to just trying to figure this out, literally, if I look at this vial of Zofran, it is labeled 4 milligrams in 2 ml. It's pretty easy math. 4 divided by 2 is 2. So that means I have 2 milligrams per ml. Every vial of medication will also tell you how much, what the concentration is. It'll clearly say on the bottle what it is. It'll say 4 milligrams per 2 mLs, and there's 2 milligrams per ml. It tells you what the concentration is. So most of the time you do not have to figure that up, but it's good to know how to do it. And that formula is going to be something that you probably need to know, that DD over AD times AB. So if I was to pull up a different one here, let's do another one. This drug I'm going to do is amiodarone. Sometimes we shorten it up and call it amio. Now, amiodarone is supplied, the whole vial, 150 milligrams in 3 mLs. Again, I can do the whole formula if I want to, or easy, 150 divided by 3 is 50. So that means I have 50 milligrams per ml. Does that make sense? And this part's kind of hard to teach online, so I need to know feedback on if you guys don't understand it, or if I need to keep doing drugs or anything like that. Don't overcomplicate it. When you overcomplicate it is when you get confused. Now, with that being said, let's take that amiodarone, for example. Let's say I had to give to this patient, I wanted to give 300 milligrams, but I'm only supplied in one vial, 150 and 3. How many mLs do I have to give this patient to equal 300?
You'd need 2 vials, 6 mLs.
Okay, 2 vials, 6 mLs. Yeah, that's literally as simple as this is. When you're trying to figure out how much medication is in each little vial or in each little ampule, you're literally just breaking down. When I say concentration, you'll hear me say concentration at all the time. I'm referring to this. How many parts per ml? That is our concentration. That's all I want to know if I ask for your concentration. How many parts are in 1 ml is what I'm referring to. So let's look at a couple of these. Let me get them pulled up here. Okay, can you guys see this Microsoft Word, the worksheet itself?
Yep.
Perfect. All right, so let's not look at that first one. Actually, I pulled up the wrong one. Give me 1 second here. That's kind of stupid. It won't let me exit off of that. Give me 1 second. I don't know what I did wrong here or won't let me pull anything up. All right, let me get this back pulled up now. All right, so first problem here, number one. Actually, let's do. Yeah, let's do number one. Okay, so everybody can see that atomidate right there, right? No issues. Everybody's all good with that?
Yeah.
Okay. So if I'm looking at that vial of atomidate, it has 20 milligrams total. It doesn't tell me how much ml is in there, but it tells me at the bottom 2 milligrams per ml. Now, okay, so if I have 20 milligrams total and I have 2 per, how many mLs do you think I have?
10.
10. I mean, that's as simple as this math is. There's nothing more. Once we try to reinvent the wheel and make things more difficult than what they are, is when we start to get into a little more trouble. Now, I'm going to pull this whiteboard back up. There's going to be a lot of switching from boards to boards on this. I apologize. If I need to, in terms of medications, oftentimes I need to know a patient's weight. And we don't figure that out in pounds. We convert everything we do to kilograms. Every medication that is potentially going to be weight-based, we are going to give based off of kilograms, not pounds. Now, there are two different methods to determine a patient's weight from pounds to kilograms. The first one is to literally, if I have a patient that weighs, let's say, 235 pounds. If I want to, try to be really good at math or use a calculator or anything like that, what I do is then just divide by 2.2. So anybody that has a calculator in front of them, tell me what 235 divided by 2.2 is.
$106.818182.
Okay, so we'll just round down to 107, roughly 106, something like that. So 235 divided by 2.2. 2.2 is what we divide for to get pounds to kilograms. Okay, I've got 106.8, 107, something like that. So we'll just put 106.8. Okay, when we are bringing pounds to kilograms, as long as we are super close, very close, it's not going to make a huge difference if we're off just a little bit. The other method that they teach you, and this is what I use when I have to convert pounds to kilograms, is cut your number in half. So take that 235. What's half of 235?
$117.5.
Okay, so 235 divided by 2 equals 117.5. I hate decimals. It's 0.5, so we're just going to round up to 118. For the 5, we're going to round up, like I said, to 118. Now, this method is dividing in half and then subtracting 10%. You can kind of see where that dot is after the 8. That's where the period is for 118. If I want to find 10%, just move that dot one spot over. Replace it. I've now got 11.8. Everybody follow me so far? 10% of 118 is 11.8. Okay. So again, I hate decimals. I'm going to round 11.8 up to 12. So we're going to get rid of that. We're just going to make it 12. Now, 118 minus 12, which is our 10%, equals what?
106.
That's how I figure kilograms. So divide in half and then subtract 10%. So one that you'll commonly often hear is 220 pounds because it's an easy number for us. Here in this instance, I divide in half. Divide by 2 gives me 110. 10% of 110 is 11. So 110 minus 11 gives me 99 kilos. Or you can just divide by 2.2. Problem is, on like your national registry, when you take that a year from now, you're not going to have a calculator. So you need to know how to manually do it. Dividing by 2.2 is great all day long, but you need to know how to manually figure it out. This is my manual way of doing it. Cut it in half and subtract 10%. So like some meds like fentanyl, etomidate, kids meds especially, a lot of those are weight based and they base it off of per kilogram. And the reason I show you weight is because there's really 4 things that we deal with math a whole lot in EMS. One is figuring out drug dosages, which we just did in the last one. One is figuring out patient's weight. Third one is figuring out how to deliver a certain amount of fluid over a certain period of time. And then the fourth one would be figuring out drip rates. So I'm going to show you 3 tonight. We're going through 2. So let's pull up that worksheet again. 2 question 1. So in this instance, it says you're responsible for providing the proper dose of etomidate to your partner so that he can initiate the RSI procedure for your patient. The patient weighs an estimated 175 pounds. You are to draw up 0.3 milligram per kilogram. How many milligrams are required? How many mLs will you have to draw up? And how many vials will you need if more than one? So, let's see if I can. See if we can draw on this bad boy. I still haven't mastered this Teams thing yet, so I apologize. Okay, I'll just go through it with you. What's 175 pounds divided by 2?
Approximately 80 kilograms.
Okay. So you got your end result was 80 kilos. Okay. So you just did divide by 2.2, I would imagine. But if we did the
Yeah.
1/6, is that what you did?
Yep.
Okay. So 80 kilos is what you got divided by 2.2. If I take 175 divided in half, that's roughly, again, I'm not good at math, 87.5. No. Yeah.
Yep.
87.5. 10% of that is roughly 9. Or we'll say 8. 8.75. Yeah, we'll round it to 8. 8.7, 87.5 minus 8 is like 79. You see how close it gets you? And the reason is that 1 kilo is not going to be the life or death difference when I'm giving a medication to my patient. So we came up, and I don't care if you do 80 kilos, I don't care if you do 79, whatever it is. I have to draw up 0.3 milligrams per kilogram. So let's use 80 kilos. How many milligrams am I drawing up total?
24.
Okay. 80 times 0.3 equals 24 milligrams. So how many mLs do I need to draw up? If you're looking at that vial, it's 2 milligrams per ml. How many mLs do I need?
12.
Yep. Okay. Do I have enough in that one vial?
No, you need 2 vials.
Bingo. That's the answer to number 1. How many milligrams are required? Well, we figured out the patient's weight, 80 kilos. 0.3 times 80 is 24. How many mLs we have to draw up? We know we need 12 because that says 2 milligrams per ml. Well, we don't have enough in that one vial, so we're going to need 2 vials of medication. All I'm wanting on these questions is you to show your math and how you got your number. Questions over that one? And please, again, if you have questions, please speak up. Okay, let's go down to number 2. Same patient. Now the patient is asleep. You give your partner the syringe of succinylcholine that you drew up. Based upon the patient's weight, the dose is 1.5 milligram per kilogram. How many milligrams are required? Remember the same patient, so we're still at the 80 kilos.
120.
Okay, 80 times 1.5 equals 120. Okay, how many mLs is that? If I look at that vial, I've got 20 per ml.
6.
6 mLs. Do I have enough in that vial?
Oh, yeah.
Yeah, if you look at the top above sucks, it says 10 ml vial. Literally, that's all this is simple math when you're trying to figure out how much medication to give somebody, or if it's a weight-based medication. Trying to see if any of these are any different. Some of these will have drips on them. Don't worry about that yet until we get into like drips next week. Don't freak out. I'll explain those a little bit more. There is a certain drip that I want you to focus on today, and that is just dripping fluid. You know, if I have to give fluid over a certain amount of time. So let's say okay, this new formula, if I need to give fluid over a certain amount of time, this formula is the amount of fluid that's ordered divided by how much time, and you do it in minutes. So if they say 3 hours, you put 180. If they say 4 hours, you put 240. If they say half an hour, you put 30 minutes. If they say 1 hour, you put 60. So we're just going to say, in this instance, time in minutes. So fluid ordered divided by the time in minutes times our drip set, the set that we're using. Now, there's generally two different types of drip sets. We have macro drip sets and we have micro. Macro, meaning larger drops, are generally 10 or 15 drop sets. And what that means is that with that drip set, it will take 10 drops to equal 1 ml. That's all those numbers mean. 10 drops to equal 1 ml. As opposed to a micro drip set, it's going to be smaller droplets because 60 of those are a micro drip set. So up here, 10 to 15 drops equal 1 ml. Down here, 60 drops equal 1 ml. So those drops down there are going to be a lot smaller than the 10 to 15. Anytime we're giving a med through a drip, we use a 60 drop set because we can refine it more. Anytime we're just giving a fluid bolus and we need to pump somebody's pressure up, we do a macro drip, a 10 or 15. So in this instance, using that formula, let's say, I need to give 500 mLs of saline over 2 hours. So remember, time in minutes. 2 hours is 120 minutes. And we're just doing fluid, so we're going to use a 10 drop set times 10. The drip set will always be told to you in any equation. This stuff will all be given to you in any equation. So first thing I need to do is figure out 500 divided by 120. Which gives me 4.16. So we're just going to say 4. Okay, 500 divided by 120 is 4. 4 times 10 equals 40. I would then put GTTS per minute. Anytime you see GTTS, what it's referring to, GTTS means drips. I don't know why we just don't put drips or drops, but GTTS means droplets or drips. So that is 40 drops per minute to equal 500 mLs in 2 hours. That's how much I need to administer every minute to equal that much fluid. So let's do a couple more. Well, I would really wish they give you a much bigger eraser than this. This is horrible. I'll leave that one up there on the left so that way you can kind of use it for reference. But please, this is the stuff you should be taking notes on. Okay. Again, different kind of fluid. Let's say we're ordered to give 1,200 mLs of fluid over 3 hours. So 180 minutes using a 10 drop set. So 1,200 divided by 180 gives me 6.6. I'll just round up to 7. 7 times 10 equals 70 drops a minute. The formulas are super easy. Just do not overcomplicate them. And I understand some people aren't great at math. I suck at math. I could probably fail 2nd grade kindergarten math. This is the only math that you really have to do in paramedic school. This is it. Figuring out drug dosages, figuring out patient's weight. Even fluid like this, in the real world, we're usually just bolusing our patient or titrating to the patient's blood pressure. But you need to know the formulas for testing. Does that kind of make a little bit of sense at all? Did anybody grasp anything from that, even if it was one thing? again, this is hard for people to understand. So don't think that, oh my God, I don't understand this right now. That doesn't mean you're not going to understand it. We beat this into your head with drugs, and it's going to make a lot more sense when you can get the drugs in your hand. And so a good thing that, and this is the part of paramedics where I tell everybody, when you're checking in your ambulances, start getting a hold of, get drug vials in your hand. Start looking at them. How much drug is in that? How many mLs are in that? What's the breakdown? What's my concentration? Start looking at your drip sets. Do you guys carry 10, 15, or 60s? Because now you'll realize that those make a difference. Again, 10 to 15 are macro drips. We need a larger droplet. Good for fluid resuscitation. Micro or smaller droplets, 60 drop sets. Start getting your hands on drugs. I'm a hands-on learner. I have to get my hands on things to understand what they are. You guys come to skills night once a week. Start getting your hands on stuff. What questions can I answer on some of this just basic stuff that I covered? If you don't want to ask me like in front of everybody, I understand that as well. So send me a message and also we can go through it.
Rudy,
Yeah.
what are the applications for macro and micro again?
So macro, your 10 to 15 drop sets, more for like fluid replacement. So maybe somebody in shock and I just need to bump their pressure up because I want those larger droplets. Kind of like, if somebody's in shock, we always say they need a large bore IV because we want more fluid. As to where a micro is more for like medicated drips, epi drips, nitroglycerin drips, just so I can more refine that medication that I'm giving them because they're smaller drops. That makes sense?
Yep, thank you.
What else? Any other questions? And you guys have 2 weeks to complete as much as you can on that worksheet. I don't base grades a whole lot around exams because people can be bad test takers. I base most of my grades around your homework and your participation and how you're doing in class generally. Are you showing up? Are you being a part of the class? Are you doing the homework that's required of you? That's what I base the majority of my grade around because that's honestly what matters to me. If there's ones you don't understand on there, like we talk about medicated drips or something like that, don't freak out, leave it blank, and we'll go through it. But I want you to do as many of you as you can on that worksheet that I put on Canvas. And again, you have 2 weeks to do it. It's not gonna be due for, I know it says the 11th online. I'll change that. It won't be due till the 18th for you guys.
Hey, Rudy, where'd you put that at on Canvas?
Let me pull it up real quick. It should be under assignments, and I just changed it and published it. So now you should have access to it. And I'll change the date on it real quick, due on the 18th. And you can download that worksheet right from there.
Thank you.
Yep. What other questions in regards to that? Okay. Take 5 minutes, look that over. I'm going to get our PowerPoint and everything pulled up. We'll start to break into that. It's only, I think, like 90 slides, so it shouldn't take us very long. If it takes a little bit longer, like I said, I try to only keep you guys here till 8. Anything past that, I think's crap. So we'll get through as much as we can. Anything we don't, we'll throw into next week because we start farm. So take 5 minutes, and I'll get the PowerPoint pulled up. All right, like I said, we're gonna jump into this medication administration PowerPoint. It's nothing crazy. Some of it's gonna seem kind of boring. Some of it might be some informational, but generally it's nothing that is all brand new. It should be stuff that you've heard of before or seen before, or stuff that we are going to talk about in the future. Things that will make a little bit more sense once we start getting into the clinical and field, which I mean is not far off. You guys have a couple weeks you have a next week of practicing competencies, so IVs, innovations, sub-Q IM, and then the week after that we'll test competencies, and then after that we'll start doing our clinical and field orientation. So clinicals are not far off for you guys at all, and getting into your field experience as well, which I do a whole orientation over that. So we'll get to that as well. But when it comes to medication administration, a lot of times people kind of put pride in the way of patient care, and they don't want to use, they don't want to call a doc. They don't want to seem like they don't know what they're doing. That's honestly, in my opinion, a load of crap. If I'm not sure of something, or I just want somebody to essentially double verify what I think I know, or I just want another head to bounce things off of, I'll absolutely call for medical direction. I might know what I'm doing, but I just want somebody to confirm it, or, again, bounce ideas off of. If you're not sure, if you're not 100% positive, should I call on this or not? You should probably be calling. That's literally what they're there for. Call the hospital that maybe either your service is aligned with, your closest facility. It might be based off your protocols, your medical director, however that works, and utilize them. By all means, they might be able to assist you in something that you might not have been able to get yourself out of without some sort of consult from them. Anytime we give a medication or think about giving a medication, one of the big things that we need to make sure, for one, is that the patient is not allergic to it. Any sort of meds that we are giving, any sort of procedures that we are doing, should be following our protocols, our online medical direction, standing orders, which is what our protocols are in themselves. The number one cause, and you can see it there in the PowerPoint, for issues with medications is not the med itself, it's that we created the error as humans. And I get it, we are going to make mistakes, and it's going to happen during paramedic school, it's going to happen during training. That's the time for it to happen. As long as you can address it and work towards fixing it, there's usually not an issue. We've never had anybody kill somebody by overdosing them or something like that. But as long as you recognize there's an issue and address it, or took it up with whoever to make sure that doesn't happen again. This PowerPoint's going to say 10 rights of medications. I can't think of 10, to be honest, off the top of my head. I've always taught 6 rights. That's honestly what they test you on, is 6 rights, not 10. And the big ones that we are looking for when talking about rights is, I want to make sure it's the right drug. Is this what the patient needs? I want to make sure it's the right dosage for my patient. Is it the right route? Should I be giving it IV? Should I be giving it IM, sub-Q? Is the drug expired? Is the drug cloudy? The right documentation. All these are things that we kind of do subconsciously. We're going through checking a drug. If I pull a medication out and I'm going to give it to my patient, it could be something as simple as ondansetron or Zofran. I'm going to give it for nausea and vomiting. First thing I do, especially with pain meds, hey, what kind of meds are you allergic to? And then if they say they're allergic to something that I think they need, I ask them what kind of allergic reaction they have to it. If they're like, oh, I just start to feel kind of funny afterwards, I've never had any trouble breathing or anything like that. Okay, that's fine. I'm going to give you the med and I'll follow it up with Benadryl. But then I also want to know, have you ever had this medication before? And have you had any side effects from it? Subconsciously, I'm doing all these things in my head. This is the drug I want. What's my dosage? And based off your protocols, you're going to memorize your dosages. If you're not sure, look in your protocols. That's literally what they're there for, is for you guys to use as a guideline or a backup or a reference. When we're checking in our trucks, and I brought that up earlier, now's the point you guys should be putting your hands on meds. You should be grabbing vials. You should be looking at them. I'm not saying pop tops off. Don't unclip things, but start looking at them. Look at the expiration dates. Know where to find those. Look at the color of the drug. Does it appear that it's a normal color? Expiration is huge. And oftentimes, yeah, you can run into an expired med. Maybe it's the end of the month or the beginning of the month, the med just expired. Making sure that you're getting that off the truck and notifying whoever so they can get you a replacement for it. Looking to see that you don't have any vials that are broken, you don't have any ampules that are broken, that you have enough meds for your shift. If it's Zofran and there's only one, I might think about grabbing an extra one or two. Do I have enough epi for cardiac arrest? Do I have enough this drug for that? Do I have enough pain management medications? Was it restocked after the last time? You can't blame it on somebody else when it goes south because it's going to fall on you. And if you checked in your drugs correctly, that's one of the things that I generally don't bypass or spend the least amount of time on. If I am checking in my truck, I'll sit in the captain's seat and I'll look at all my drugs. I'll also pull out my protocol book. We have a drug section and I'll make sure that all those drugs are in there and look and see if I have enough for whatever call I think we might have that for that day, or just enough to run any call at that point. In anything we do, we try to maintain a clean environment. Now, are we going to ever get anything 100% sterile? No, not in the field at least. In the OR, yeah, they scrub in, they scrub out. Even in the ERs or ICUs, you'll see some sterile procedures where, they're putting on sterile gloves and somebody's essentially pulling their glove cuffs down for them. There's sterile equipment that's being used. We don't always have that option in the back of an ambulance, but we try to keep it as clean as possible through sterilizing reusable equipment by using things such as Sani wipes, whatever it is that you're using, whether it be a wipe, whether it be like Cavicide spray. That's our way of disinfecting things. One of my mentors when I was becoming a paramedic, what they would make us do is we would go through, we had an actual display ambulance when I went to Mercy College in our old building. And we would have to, one of the skills classes was us cleaning the ambulance. We thought it was the dumbest thing in the world. We literally sat in there, wiped the ambulance down, talked, whatever. They came in with a light afterwards, like a black light, and showed us where all the dirt was that we had missed. And it kind of opened our eyes a little bit. Same thing with hand washing. All the areas that you don't think about showed us where those areas were still dirty. Now I clean my ambulance before I go out on any call, and I clean it when I'm done with it before the end of my shift. Some equipment's reusable, some of it is disposable. Seems like we're moving more towards disposable than anything at this point. For it to be totally sterile, you need to have sterile equipment, sterile PPE, such as gowns, gloves, glasses, usually, a little cap. There's a difference between keeping things sterile versus keeping things clean. If I'm going to sterilize something, I'm using a chemical or I'm using heat to break down whatever organism I think might be causing harm. Think of dirty water, or like if somebody's putting a boil advisory, your town is putting a boil advisory because chemicals in the water. They want you to boil the water before you drink it. That's because they want you to sterilize it. They want you to kill whatever organisms are alive in that water. So they're asking you to sterilize it at that point. Again, is it going to be 100%? No. And you're going to have those calls where you get back, and the back of your ambulance just looks absolutely horrible. I'm guessing you've all, if you work in EMS now, you've been to the hospital, you've seen that ambulance, so you walk past and you're like, what in the hell happened back there? That happens. It's not that hard to clean up. Blood, whatever, liquid, whatever it might be. Take the time to properly clean your stuff. Anytime we are using anything that is going to be penetrating a patient, needles, lancets, anything like that, those all need to go in sharps containers. Technically, IV catheters, the little plastic catheters, should be going in sharps containers as well because they're biohazard. It's not because they're sharp, but it's because we're not going to throw it in the trash, because technically it could tear through the trash bag, and then we've got something that has opened a can of worms into, whoever's handling it at that point. Most ambulances have a handful of them in the back of in the box of your rig itself. A lot of services carry sharp shuttles, which are little mini sharps containers in their first out bag, maybe in their IV kit, whatever it might be, just so they can, if you're in the house starting an IV or something like that, they have a means to get rid of that sharps right there instead of, throwing it on the floor or whatever it might be. When we talk about giving fluids, it's our body relies off of fluid. Our body is a lot of water. We are essentially vessels that haul around a ton of water. I mean, our body is comprised mostly of water. You can watch somebody's weight change up to 12 pounds in one day alone, just off of water weight. You know, we think of patients with edema that are really swollen. We think of patients that are really dehydrated, where you can like grab their skin and pinch it and it'll stay in that shape, what we call tenting. If patients become dehydrated, they can essentially go into shock. They don't have enough circulating volume. You'll start to see them turn pale in color because, again, they don't have enough circulating volume. If they are overhydrated, they will appear to be puffy and have what we call edema or swelling, to where you literally push on their skin and you can leave an indent, almost like a waterbed. Now, there's going to be some some illnesses or injuries that can cause this as well. You know, traumatic injuries can cause hypovolemia. Sepsis can cause dehydration because your body has raised its temperature. It's burning through that. If we don't keep those patients up on fluid, then we could potentially see them go in shock. You know, think of you boiling a pot of water. If I fill up a pot of water with barely anything at the bottom and turn it on high, that water is going to dissipate very quickly. If I fill that pot up, it's going to take a long time for that water to boil, and so it take a hell of a lot longer time for that water to disappear entirely. Some of the common things we look for to determine if somebody's dehydrated, and this could be due to heat, it could be due to illness, it could be due to, you know, maybe it's a chronic issue such as issues with their kidneys, maybe it's somebody that has cancer or something like that. The big things that I look for is I look for an elevated heart rate. That's one of the first things I look for, because as your body starts to see a drop in circulating volume, the heart says, okay, it's a problem with me. I need to speed up, because obviously there's a problem with fluid. It has to be on me. So you will see the heart rate start to increase at that point. That's a really early sign that your patient could potentially be going into shock. Positional hypotension, what we call orthostatic vital signs. So if I have somebody sitting down, I take a blood pressure, they stand up, they start to feel dizzy right away. If I was to take a blood pressure on them again, I'm guessing their blood pressure would be significantly lower from when they were sitting, because now blood is rushing to their lower extremities. I'm going to see that drop. If they're not properly hydrated, it can cause syncope or blackout episodes. Poor skin turgor. Their skin will appear tough. When you pinch it, literally, it will stay in that pinch position because there's no fluid behind it. It's literally what we call tenting. Now, some of the common things that we can see that could cause dehydration. Diarrhea is huge, especially in our pediatric populations, along with vomiting. But you could also see that with, I mean, think of our, 2 a.m. alcohol patient. Drank too much, they're feeling like crap. Maybe they're unresponsive, I don't know. We start IV fluids on them for 2 reasons. 1, to thin out their blood of the alcohol, and for 2, if they've been vomiting a whole lot, I want to make sure that they're still getting the fluid that they need. I mean, think of a really hot day outside. You're sweating a lot. You're burning through all the fluid that you have. You'll generally drink a lot more water. That's why we always try to tell people to stay hydrated. Infections will cause dehydration. As you have an infection, your body raises its temperature. It has these little, almost like fighters inside of us called pyrogens. And when an infection is detected, these pyrogens kick in, and their job is to raise our body temperature, to try to burn out whatever the bad stuff is. Well, by raising our body temperature, we burn through fluid faster. Hemorrhaging, massive hemorrhaging can cause dehydration because we're losing volume. Environmental emergencies such as heat strokes, heat exhaustion, even on the opposite side of that, more your cold emergencies. People that don't drink enough fluid. You know, we always used to preach based off the color of your urine, you can tell if you're drinking enough fluid. That's pretty true, to be honest. Here's an example, a good picture of when I talk about overhydration, edema. That swelling that, literally I can leave my fingerprint in. That's what we call pitting edema. How long is my fingerprint going to stay in that position? You can also see that with congestive heart failure patients, CHF patients, and their lower extremities. One thing to consider is if their extremities are doing that, is there a potential that their lungs are as well? Your lungs will be one of the first organs to back up with fluid because it's connected essentially directly to the heart. So if the heart can't adequately pump this because there's too much fluid, you will see the lungs start to fill up and we'll hear sounds such as crackles. Hence why CHF patients have crackles when we put them on CPAP, is because they have that fluid backup due to heart failure. Now, some reasons somebody can be overhydrated. Kidney issues. Maybe their body isn't filtering like it should. Water intox, especially if you played sports a lot when you were younger. You know, I played 4 years of football. I can remember times during practice, it was like 110 degrees outside. Only thing I wanted was to hit the water fountain. I'd run up there, drink as much water as I could, and I was vomiting like within 5 minutes because I had put so much water into myself that I'd create gastric upset. For us to deliver so much saline that we've overhydrated the patient, we're gonna have to be with them a little bit for a little period of time to cause that, to be honest. But most commonly what we're going to see is this is going to be patients with renal problems, with kidney issues that aren't able to filter what they have, so their body just holds on to it. Another thing with overhydration is people that have a high sodium diet, that eat a lot of salt. Their body's going to retain water because water follows salt. Water naturally will follow sodium around. That's why they always say if you're stranded in the ocean, don't drink salt water, because it'll cause you to become thirsty quicker, because you're not going to eliminate that. Your body sees salt, water in your body is going to follow that salt around. So as long as the salt's in your system, your body will retain fluid. Now, the IV fluid that we are most commonly going to be dealing with is sodium chloride, 0.9% sodium chloride. That's going to be our normal saline. It does have a minor amount of sodium to it, hence the saline part. But generally, the amount that we're going to give isn't potentially going to be harmful for a patient. Maybe it's somebody you're taking on an interfacility transfer, or you're taking them from one level of care to another higher level of care. Yeah, you might have to be careful in those instances. If I'm giving a ton of fluid to patients, there's a couple things I'm checking. I listen for lung sounds to make sure I'm not overhydrating them, and I also check their extremities every now and then just to make sure that I'm not starting to see that puffiness. Since it is salt water, technically, you can see their body start to retain fluid for a short period of time. But once enough fluid is delivered, their body will then wash out the sodium in their system. But 0.9% sodium chloride is what we're most commonly going to deal with. And why electrolytes are a pretty big deal is electrolytes are what our body uses to maintain homeostasis. This could be sodium, potassium, calcium. Those are electrolytes within our body. Now, in any of these cases that you see here, excessive vomiting, diarrhea, dietary issues, meds, blood loss, we are losing electrolytes. And the problem is, even our heart relies off those electrolytes to create electrical impulses to properly beat. So if we have those electrolyte losses, we can start to see organs start to fail. We can start to see body systems start to fail. We can start to see the patient become sicker. The big ones that we're going to most commonly deal with are going to be potassium, sodium, and calcium in terms of electrolytes. That's why drinks such as like Gatorade and Powerade, they always say they're electrolyte rich. Just for that, during sports, they're probably burning off a lot of electrolytes, sweating, exercising, so that is a good fluid replacement. There are some other IV fluids that could potentially be given. To be honest, the one we're going to deal with is 0.9% sodium chloride. Maybe your service carries lactated ringer, but you can look at the electrolyte compositions of each of those. Lactated ringer is going to be the one that has more than just sodium in it. If you look towards the bottom of the chart, it's going to have chloride, potassium, calcium, not magnesium at all, as opposed to those other normal salines. There's different variations. Those are primarily going to be sodium chloride, hence the name. They're not going to have any potassium. They're not going to have any calcium. They're not going to have any magnesium. Why that's also important is that during an infection or a patient, experiencing some traumatic blood loss, lactated might be given preferred over saline, because it's replacing some electrolytes, as where saline is not going to replace any. Remember, saline carries nothing. It's basically just salt water. A good rule of thumb is that if we're going to be replacing body fluid with the saline, for every 3 bags of saline we give to a patient, we should be giving 1 liter of blood. Another thing that they say is 3 mLs of saline to 1 ml of blood. It's the same concept. The problem is saline carries nothing besides salt. So in those traumatic hemorrhage situations, we can see pulse ox drop because we don't have hemoglobin. We can see clotting factors decreased because we don't have fibrin. We don't have fibrin in the blood. We are literally thinning blood out by giving these patients a ton of water. Crystalloids, as you can see at the top, is going to be what we're most commonly dealing with. This is going to be our normal saline. This is going to be our lactated ringers. These are going to be the solutions that we're going to be administering to our patients. Now, when we give fluid boluses, like you see at the bottom there, a fluid bolus for an adult is usually 20 milliliters per kilogram of body weight. We don't give it to maintain blood pressure. We do it to maintain perfusion. So something that's happened in the last 5 years is we no longer try to maintain that 120/80 blood pressure, especially in the case that the patient's kind of going downhill quick. I'm trying to maintain 90 systolic at that point. It's what we call permissive hypotension. Just enough to perfuse their vital organs. I'm not trying to spike their blood pressure because as blood pressure increases, I could potentially be washing away clots. And it's not just bleeding I can see. It could be intra-abdominal bleeding. It could be any sort of brain bleeding, anything like that. I want to keep the clotting factor going. I don't want to wash those clots away. As to where instead of crystalloids, we also have colloids, which is going to be more of, it's going to be more of a viscous solution, to be honest. It's going to be used more for patients that might have severe swelling or severe edema. And the reason for that is it'll cause the fluid to shift into their cells instead of out of their cells. When we shift the fluid from extracellular into intracellular, it should remove that puffiness and that swelling. I don't want you to pay a whole bunch of attention to this, so don't get freaked out. I just want you to know these 3 different categories. Isotonic. What that means is if you look at that middle picture, there are equal parts salt between the outside of the cell and the inside of the cell. So water is going to be perfectly balanced because remember, water follows salt. Now, hypertonic would be when there's more salt on the outside of the cell than there is the inside. So then water will literally leave the cell to go sit in the spaces. That's when we'll start to see edema with our patients. As opposed to a hypotonic solution, hypo meaning below or lower, that's where we're going to have increased sodium parts in the cell. So we would see fluid come from the inside, from the outside into the inside of the cell. The one thing we can't replace is blood. We can try to administer as much saline as we want to keep somebody's blood pressure up, but what they ultimately need is blood. You know, we don't just call a helicopter for its ability to transport somebody quickly. We call them because they carry blood products. They carry whole blood, and they carry packed red blood cells. We are not going to give a massive amount of fluid to really keep a patient alive. And if so, we've thinned their blood out to the point that they're probably not conclusive with life at that point. You know, when we talk about giving fluid, we talk about starting IVs. You're literally inserting a foreign, sharp object into your patient's body. That's why we try to keep our equipment as clean as possible, because I don't want to create an infection, especially, you know, that's somebody's grandma, that's somebody's mom. If that was my relative, I'd want to know that the equipment was as clean as possible. Try to keep these things as sterile as possible. And I get it, in the real world, it's not always feasible. We're starting IVs in fields, we're starting IVs on gravel roads, whatever it might be. But we try to maintain as clean of an atmosphere as we can. I'm not even gonna say sterile. We just try to keep it as clean as possible and constantly disinfect things. This goes back to our drip sets, 2 different sizes. Micro drips, a lot smaller drops. So it takes 60 of those to equal 1 ml. As to our macro, much larger drop, it only takes 10 to 15 to equal 1 ml. Most drip sets do have like a plastic cover over that spike. That's keeping that spike sterile for you to insert it into the bag. Don't try to keep that as clean as possible. Don't drop it on the ground or anything like that and pick it back up. Drip sets are cheap. If you drop it or step on it or something like that, just throw it away and grab another one. Veins are going to be pretty, as far as anatomically location, pretty similar in most people. It just depends on the person's anatomy. You know, the ones that we're going to primarily see or try to come in contact with when we're starting IV is going to be right here in our lower arms, maybe up towards around our bicep area. But you have a massive amount of veins in your lower arm, even in your hands. But the problem with your hands is you can see it looks like a spider web of veins. So sometimes you're not going to always get that true straight vein that you need. Some places, I've seen it before, they'll start an IV in somebody's foot. People usually have really good foot veins. And they're usually very easy to see because tissue on the bottom top of your foot is usually really thin. Now, in the instance that we're not able to find a vein, we can do what's called ultrasonography. So kind of like an ultrasound. Some places will use what's called a vein light. And what they're doing is literally finding a vein, and they're using that to guide their needle into the vein. Very much like an ultrasound of, like, you know, if they're checking for, you know, somebody's pregnant, they're at a checkup or something like that, they're doing an ultrasound of the baby. It's very much the same imaging. You'll be able to see the veins, and they'll literally watch as they start the IV and be able to follow it into the vein to know that they are properly placed. And then when they give the fluid, they'll be able to see the vein kind of engorge a little bit, as opposed to the fluid being on the outside. You might have a chance to see those in the ERs, especially if they have a patient that's a really difficult stick. If all else fails, it's one thing that we don't commonly do because we usually will find an IV site. We do have the external jugular vein, the EJ, which runs along the side, each sides of your neck. Usually the easiest way to get it is by sitting the patient up almost at like a 45-degree angle, turning their head at a 45, and you can see right there, that guy has a great vein on the side of his neck, his EJ. The only thing you have to kind of be cognizant of is when we start an IV, generally the catheter is pointing towards the heart. Well, in this instance, the catheter's got to be faced the opposite way because, again, it's got to be pointed towards the heart. You're not going to start this facing up like you would in the lower extremities. You're going to start this one facing the heart. If you're unsure if that is an artery or vein, you probably shouldn't be starting an IV on it. Or, like this says, check for a pulse. Now, I can tell you when you're nervous, you're probably going to feel a pulse every single time because you're going to try to talk yourself out of it. But there are the instances where EJs are very beneficial, especially in patients that are crashing or you need to get access really quickly. Turning to that EJ is not a bad alternative. Some people, you can literally be talking to them and they'll turn their head and you can see their EJ. Other people, it really just depends on their anatomy. I'm a big guy, I have a big neck. You're probably not going to be able to find EJ on me very easily. As opposed to somebody that's thinner, maybe a little bit lankier, finding an EJ on them is going to be a lot easier. When you are finding, and this goes for elderly patients as well, sometimes you have to pull traction, and so literally it's almost like spreading the skin apart where the vein is because you don't want the vein to roll and you want to hold the placement. So if you use like your thumb and your index finger where you're going to start the IV and just kind of spread apart to kind of keep the skin tight so that way the catheter is going to pass through the skin a lot easier, especially in our elderly population. Their skin is going to be tough. It's going to be rigid. So starting IV on them might not be the easiest, but by spreading it, it gives us a better chance at getting a successful stick or successful cannulation. This is what I struggled with the most going through paramedic school in terms of IVs. I'm what you call color deficient. I can't tell colors very well. I still to this day cannot tell you what color IV catheters are. I have to read the package. But each color on the catheter corresponds to what size it is. our 24 gauge, we're used more on our pediatric populations. 22 could be peds, also our elderly patients, because remember, elderly patients are gonna have a little bit smaller veins. Generally, for your normal adult patients, I'm either going with a 20 or an 18 gauge, depending on the size of the vein. They'll always say use the largest catheter available for the vein that you have, which I agree with, but I generally am not gonna stick somebody with a 14. I've never done that in my career. Those are reserved for, some people use them for decompressions. Decompressions are generally a 10 gauge, but I have seen it where some people carry 14 gauges. I've started a couple 16 gauges in severe traumas, but the studies have proven that the difference between 18 gauge and a 16 gauge is so minute, and you have such better chance of getting an 18 gauge versus a 16. It might be more beneficial to go with 18, but for normal run-of-the-mill patients, our 20 and 18s are going to be pretty standard. Remember, the higher the number, the smaller the needle is going to be. I would get to know your colors of your IV catheters, because I specifically remember a question about colors of IV catheters on my national registry. Now, kids are going to be difficult. Try to tell a kid you're gonna poke them with something. It's hard. Now, if you can distract them, you have a better chance. Or if you can gain their trust. One thing that I like to do with kids is take a IV catheter out, pull the catheter off the needle itself, the plastic part, show the kid that it's just plastic, it's not sharp. You're kind of tricking them a little bit. But I'll also tell them, hey, look, I'll poke myself with it. It doesn't hurt. And I'll say, hey, if you let me poke, if I can poke you with it, I'll let you hold it and I'll let you poke me with it. So then when I go to poke them is when I'm trying to start the IV on them. When it's all said and done, they do the same thing to me with their little catheter, and it's just a little plastic straw at that point. Some kids, you can use like a flashlight on the opposite side of their hand just to illuminate any veins that you think might be there. It might help you find some placement, it might not. Kids are going to have really small veins. That's why we use very small catheters on them. And it's going to be very similar for our adult patients. In our elderly patients, we're going to see veins like that, varicose veins, spider veins. Those are not good veins to cannulate in. Those veins are not straight. They don't have the structural integrity to hold an IV. They'll blow really quickly. Don't even try them. Also, be careful in our elderly patients if they're on blood thinners. They will bleed a lot. And not just elderly patients, any patient that's on blood thinner. We have to be kind of careful that, it brings up tape may damage skin. Yeah, elderly population have really thin skin. So taping and pulling that tape off can tear their skin, absolutely. And they also bruise a lot easier than anybody else when we start an IV, especially if we're removing it wrong or we're, fishing. We're trying to find that vein with that needle in there. You can start to see some pretty severe bruising in patients. I had an IV started on me probably, I don't know, less than a year ago, 6 months ago. And for 2 weeks afterwards, my whole forearm was bright purple from them trying to find a good site to start an IV on me at. Now, after you start an IV, it's all taped up, it's locked, it's all ready to go. Some things that we're checking: am I using the right fluid? Am I using the right set? Do I have everything ready to go? One thing I always check as well is my location. Is this a place where I think the patient is going to bend their arm a whole lot, like their AC? If so, I'll usually put Coban around it. It's not going to stop them from bending it, but it'll remind them when they go to bend their arm that there's something there. And you'll also hear that as well. If I'm in the back of the ambulance, I'll say, hey, try to keep your arm straight for me. And oftentimes I have to remind them or kind of stop them from bending their arm, just so they don't lose that catheter at that point. If I'm going to be giving fluid, making sure that my IV bag is high enough, the fluid can use gravity to go into our patient. Now, if I am to blow a vein, I get complete infiltration. I'll know because the second I go to flow fluid, because I'm checking the patency of the vein, I'll literally start to see swelling. It'll look like a lump raising right around the vein. At that point, we're done. We blew the IV. We need to DC it or remove it. To do that, we literally grab a 2x2, place it over the IV site, pull the catheter out. By continuing to push fluid in it, we're just going to create bruising. We're going to create swelling in that area. If you lose it, you lose it. Try in a different extremity. Now, there are also the instances where an IV catheter can become occluded. This could be due to a valve. This could be due to lock being pinched. This could be the patient banging their arm so that the catheter is pinched. There's a whole bunch of things that could be causing this to be occluded. If that happens and you lose your sight, then you're probably starting the other extremity at that point. Often for me, if I try one extremity, it doesn't work, I ask my partner, whoever I'm with, hey, can you look in the other arm? Or I'll have them looking while I'm looking at one arm, just for if whoever gets sight first and like, hey, I got one over here, I might have one as well, but then I'll use theirs as the backup. There's a good example of the bruising we could potentially see. As you can see, that's an elderly patient. That bruising is probably from, I'm guessing, more than one stick, although they only have a Band-Aid over one. But you can see they've tried multiple times. You can literally see the lump right below the wrist where it looks like fluid was pushed before they finally got a successful IV in their hand. Same thing happens to my grandfather. Grandfather's 87 years old. He recently went to the doctor, had to have blood drawn, and he bruises really bad just because of simple trauma. And we don't think of what it can do to the patient, especially if they're on blood thinners. That bruising is blood, right? That bruising is damaged tissue. So while we're in there trying to start an IV and we're fishing around for a vein, just remember that we're causing some damage with our patients. And in regards to that as well, can we be causing nerve, tendon, or ligament damage? Absolutely. If you accidentally mistake a tendon or a ligament for a vein, yeah, that's a problem. Can we start arterial lines? Absolutely. Those happen accidentally all the time. But it's knowing what to do at that point. If you accidentally hit an artery, don't pull your catheter out right away because the patient's going to bleed all over. If I successfully stick an artery, I will generally leave it in place, lock it off, and let the receiving facility know, hey, I accidentally started an IV in their artery. It's not a huge deal. You're going to probably see it in the ER. You're probably going to do it at some point in your career, in your paramedic school education. All we do, apply direct pressure, occlude it, hold it for about 5 minutes, and usually the bleeding subsided at that point. Now, if for some reason, anytime we start to give a medication, a fluid, or anything like that, and the patient is starting to have a bad reaction to it, such as a pyrogenic reaction, this is, remember, their body starts raising its temperature, stop what we're doing. Stop giving the fluid, stop giving the med, whatever it is, stop what we're doing. That's the first step we should be doing. And then reassess our patient and see what we did wrong. So when you start to get an adverse reaction, stop what you're doing and reassess what you did and what potentially caused this issue. If for some reason you think you've given your patient too much fluid, I'm probably going to stop the fluid at that point. I'm probably done administering it. There's not a whole lot more you're going to do besides that, besides monitor your patient. The reason we flush all of our IV lines, we flush all of our locks, we make sure that they're primed and ready to go, is to prevent any sort of air embolus. If we inject air into our patients continuously, yeah, we have the potential for an embolus to, part of their vessel to become blocked by an air bubble. It usually is going to take a little bit more air than just a couple bubbles, and all the time we're going to have a couple bubbles here and there. But this is like, a saline lock in itself holds 2 mLs of air. That's a lot of air if you forget to prime your line. Same thing goes for your drip set. Make sure you prime your drip set before you hook it up to your patient. Make sure all the air is cleared out of it before you hook it up to your patient. If for some reason you think that you administered too much air, honestly, just monitor your patient on the way in and assess them continuously, assessing vital signs. They're saying place the patient on the left side with the head down. That's what we call the recovery position. I don't even know if I'd say that. And the reason they're saying that is they don't want the air embolus to travel to their brain. But again, just monitor your patient. If you forgot to flush your lock or prime it or something like that. I don't think that's ever happened to me in my career. Hopefully it doesn't ever happen to you, because that can be bad juju. Now, if you are starting IV or pushing a med or something like that, patients can vagal down. And remember, as a patient vagals down, they are going to see a drop in their heart rate. When we see that drop in their heart rate, we're going to see a drop in blood pressure. Well, if I'm giving a med because they're already critical, I don't want to see that drop in blood pressure. But you can see that as a reaction to starting an IV. Or, based off of something you gave. Maybe it's a fluid that didn't agree with the patient. Maybe the patient's really sick and you gave them medication that didn't agree with them. You can see them bagel down. I'm gonna go like 10 more slides, and I'll give you guys a break. If for some reason my catheter, either I take it off and push it back on the needle and it shears, meaning I created a new opening with the needle, it didn't go straight through. I bent it or whatever it was, and I broke through the side of that catheter with the needle. We call that catheter shear. Not good, because I've now created a little bit sharper object, which I'm going to place in the patient's vein. If I shear the catheter, I'm going to start all over. I'm grabbing something new. Don't try to reuse it. That's why we don't, if you pull the catheter all the way off, that's why we don't put it back on the needle. It's okay to move it just a little bit, just to make sure it doesn't get stuck on your needle. But there's a reason we don't pull that catheter all the way off and put it back on, is because we're afraid of catheter shear at that point. If the catheter shears off entirely and a part of that is broken off inside their blood vessel, then we've got an issue. And you often see some people, they'll go to start an IV and they'll advance the catheter and they're not in, and they'll push the needle back in to the catheter. That's where catheter shear could happen, is because we can't see if that needle is going straight through the catheter at that point. If you guys are going to obtain a lot of blood during paramedic school, especially in the ERs, when patients come in, you're probably going to be drawing labs on them. Now, these are going to be the most common colors that you're going to be dealing with: red, blue, green, and lavender. Finding out from your nurses what colors they want drawn is going to be pretty pertinent to if you're successful in the ER or not, and if you're following their directions. These are generally self-sealing tubes, and how we draw them up is you can technically draw them up into a syringe and then insert that syringe into those vials. But more often than not, what we see is what's called a vacuumtainer or vacutainer, which is very much the same as starting an IV, except instead of hooking a lock to my IV catheter, I hook this little container, or this little vacutainer. It doesn't allow blood to come out. It's a one-way valve. It has a piercing nozzle inside of it. As soon as I push a vial onto it, it'll automatically fill the vial up with blood. Now, when I'm done with that, I can occlude the vein, remove that vacutainer, and then I can still use that vein for IV access. That is how you're going to be drawing blood in the ERs, using that vacutainer. Sorry, I skipped the slides that tells you how to do it. You're going to be doing that in the ER. The first time you have to do it, ask your nurses questions. I can't teach you in lab or anything how to effectively draw blood, because unless we're drawing blood on each other, we're not going to get the back pressure off a mannequin like we would in real life. The first time you have to draw blood, ask your nurse questions. Hey, what's the proper procedure for doing this? Because each facility is going to be different on how they draw blood. You're not all going to be at the same facility. Double check with your nurse that you're assigned for the day on how they want blood drawn and what colors of blood they want drawn. Ask them questions. Don't just sit there and be a stone. Ask questions. I thought drawing blood was one of the coolest things in the world during my clinical time in the ER. I absolutely loved it. It made me feel like I was important, like I was doing something. Now, in the event that we have to give blood to a patient, not us, but in the clinical setting, what they do is what's called type and cross match. And what they're doing when they're typing and cross matching is determining what blood types the patient has so that they can get that from the blood bank to administer to the patient. Now, in severe traumas, what they're going to do is administer O negative. O negative is the universal donor when it comes to blood. So in severe, we need blood now situations, you're going to see the patients get O neg. Now, once the patient is stabilized, they might type and cross match to determine their blood type and then get the proper type to administer to them. Giving blood is not something that happens very common pre-hospital, maybe maintaining it if you're a critical care service. But most of the time, we're going to see that done in the clinical setting or in flight. because blood has to be run through its own IV tubing. You can't just use a regular drip set for blood. There's like filters in line and different drip sets. The tubing itself is different just because blood has a different viscosity as opposed to fluid. And there's a little more training that's involved with giving blood than just sitting and going through a PowerPoint. Now, a lot of times if blood is given to a patient and they have a bad reaction to it, we need to stop what we're doing immediately as far as transfusion goes, because something is happening that the patient's body isn't agreeing with at that point. All right, take another, let's take 6 minutes. We'll come back, or let's do 7:38. We'll jump into IOs. We're over halfway done with this PowerPoint. So I'm going to try to get you guys out of here, like I said, 8:15-ish. We'll jump in, talk a little bit about IOs. That's what we're going to be doing in lab this week. So it makes a little bit more sense. And then we'll answer any questions towards the end. So take till 7:38. All right. In the instances that there's certain instances, some places will, if it's a cardiac arrest or, unable to obtain IV access relatively quickly in a patient, or, they've attempted IV access and it's just not working. You have the option to go to an IO, or what intraosseous infusion is the correct term for it. What we're essentially doing at that point is placing a needle into the spongy part of the bone, into the area where fluids and medications can still be absorbed, because we do have blood vessels within that spongy part of our bone, if you're looking at that diagram right there as well. Now there's certain spots, because there's bones that are thinner than the others. There's areas that are really bumpy, and we try to find the flattest areas to be able to do this, because we want to try to insert it at a 90-degree angle and have a decent area to obtain access. We're not shooting for a super small area. We want to have a larger area just so it's easy to find. There are instances where IOs might not be possible. And this could be patients that have fractures, maybe infections, patients that have amputations of those extremities where we are not able to do an IO. The IO was originally brought about from the military. In the military, they do sternal IOs. They're kind of gruesome looking, to be honest, but they work. They're effective. Well, everything we do in the civilian world, at some point, it seems like was done in the military world as far as medicine goes, because they've kind of figured out what works and what doesn't. Even when you talk about like tourniquets and things like that. The problem with IOs is that pushing meds and pushing fluid through them is not the easiest. That's why we always have to put them on a pressure bag, is we pump that up, or you've even probably seen some people use a BP cuff to administer fluid through an IV line that's in an IO. Meds such as like dextrose or D50 are going to be super difficult to push through an IO. The times that I've done it, literally my hands are shaking the whole time while I'm giving it, because I have to apply so much pressure to get that medication into where it's supposed to be going. Now, as far as onset, it's going to be very similar to like an IV. It's going to absorb really quickly, the exact same time as an IV, to be honest. But it is a little bit further away than most IV access we're going to get. Common places we're going to be doing it is this. We're not doing sternum, that's military. The humeral head, so like our shoulder, our ball and socket of our shoulder, or our proximal tibia, what we also call the tibial tuberosity. Easy way to find it is if you get your own knee, for adults, if you go 2 finger lengths width below your kneecap and 2 finger lengths to the side towards the inside, what we call medial, towards the middle, you will feel flat spot. That flat spot is what we're aiming for when we do an IO. It's a flat bony spot. There's also different sizes of needles. Pink is generally for our pediatric population. Blue is going to be more of our adults, and then yellow is going to be if we need for the patients that maybe have a little extra tissue, or if we need a little bit longer needle, we can use the yellow one as well. Now, these different sites and what they look like. So top left would be like our humeral head. In terms of finding the correct anatomic location, it's literally, if you can feel that ball on your shoulder, like if you feel in through the tissue, you can feel that ball, that bony part, that's where you're drilling into. But when you do it, you generally have to take the patient's arm and fold it over their abdomen so that their arm is like resting on their stomach, because there's a muscle and a tendon. And once you rotate their arm like that, it moves that muscle and the tendon out of the way so that you're just going to bone and not damaging any muscle or any tendons. Not very common, because again, if I need to do it, the patient, in my opinion, for anatomic location, sitting up is the best. Well, when I need an IO, a lot of times these patients are unconscious. So my go-to is usually the bottom one, the tibial tuberosity. And again, two fingers down from the kneecap and 2 fingers towards the inside. You'll feel that flat bony spot. There's an example of our sternal IO. That's again military. That has like 12 needles, if I'm not mistaken, instead of the 1. Times that I've, there's some places that for training, somebody will do a conscious IO on somebody else. The needle in the drilling doesn't hurt. It's once you go to push fluid, especially if the patient is conscious, because we can do conscious IOs. Once you go to push saline or anything through that, it's extremely painful. Kind of like if you have an exposed nerve and you need a root canal in your mouth, very similar to that. That's why if it's a conscious, we try to follow it up with lidocaine to numb the area before we start to give any medication. Now, these are old school, manually inserted needles. These we would literally use pressure, apply pressure, and then the back was essentially a knob that you would turn to create that rotating motion, to create that centrifugal force to drive that into the bone. I don't know anybody that still carries manual IOs at this point. The next one I'm going to show you is more what the military uses for sternal IOs. Again, that's going to have like 12 needles. It's what's called a fast IO, just meant for sternal IOs. The problem with fast IOs is you have to have a special key to remove them, as opposed to the ones we're used to, the easy IOs. Can just be pulled out once we're done with them. There's your 3 different sizes: your pink, your blue, your yellow. 15 is your smallest. 25 is your middle for your adults. 45 is going to be people that are a little bit larger in nature or stature. And again, that's what we're covering in lab this week, as well as IO insertions. Now, applying too much pressure to an IO, especially if the patient has like a history of osteoporosis or something like that, can cause bones to break, can cause bones to fracture. You can absolutely, just like a patient that's going to have a PE or anything like that, that maybe has had a recent surgery or a recent injury, you're essentially, if you do this incorrectly, are creating an injury. This has a potential for a patient to throw a PE because of what we're doing. Usually when we start the IO, you will feel a pop once it's inserted, and it'll get really easy. That's when we stop. We also don't start drilling as soon as that hits the skin. We push through the skin before we start drilling. We want to hit bone before we start drilling. You pull the needle off the back. I usually hook a syringe to it at that point, and I pull back to see if I get any blood or bone marrow return. And if so, I know I'm good on placement. I'm going to then flush fluid at that point and just make sure I don't have any infiltration or any swelling around the site. Now, some reasons we're not going to do an IO. Okay, people have weakened bones, such as osteoporosis. And I get it. There's some instances you're not going to find this information out prior to you doing it. Obviously, if the patient is an amputee or has a prosthetic, probably not going to work because you're not drilling into bone. If you have an IV that you can use, do not do an IO. For one, it's not needed. For 2, IO needles are super expensive. They're around $200 per needle. If you're going to do an IO, make sure you can identify your landmarks. If you can't identify your landmarks, then you're essentially drilling blind at that point. Now, there's a reason I gave you guys your drug cards so early on, and these are all things that are listed on your drug cards. How does the drug work? Why do we give it? Why do we not give it? What are the side effects you'll see? What routes do we give the drug? What are our dosages, and how do I reverse that drug if I need to? Fentanyl, I give Narcan. It's a good example. These are all things you should be putting on your drug cards. I talked a little bit early on about weight-based drugs. Some of your medications are going to be weight-based. A lot of pain medications are weight-based, such as fentanyl. Some protocols say 1 microgram per kilogram of fentanyl. It's going to be the same for kids. All kids are generally weight-based. That's why if we need to find the correct weight for a kid, or we need to find the right drug dosage, we use a Broslo tape, also called a length-based resuscitation tape. That will literally tell us the equipment we need. It'll tell us our drug dosage, and it'll tell us how many kilograms this patient weighs, so that we can manually figure out our drug dosages if need be as well. So anytime we talk about peds and drugs, always refer to a Broslo tape. If you can get your hands on a Broslo tape and look at it, I guarantee in your peds bag or whatever at your service that you work at, if you work at one, guarantee there's a Broslo tape in there. Anytime we refer to enteral meds, it's anything given through the digestive tract. This could be pills, this could be lozenges, kind of like a cough drop, tablets, any sort of syrups. These are things that the patient is going to eat, swallow, instead of having an IV or instead of getting an injection. The problem is these are going to absorb generally a lot slower than an IV med or a sub-Q med or an IM med. You know, you can see upwards of absorption up to an hour, depending on the drug itself and the route that you gave it. Something we don't do all too often. There's only a handful of medications that this would be indicated for. Rectal administration of a medication. There's two that I can think of right off the top of my head. One would be seizures of a kid. You need to give like rectal diazepam. Sometimes that's prescribed to patients. Or you need to assist the parents because they're familiar with this and they know what they're doing. Some protocols I've also seen where you can give dextrose or glucose rectally to raise blood sugar if you have no means of getting no means of access anywhere else, because the digestive tract is very quick to absorb things and then it carries throughout our circulatory system. So that's enteral, anything through the digestive tract. We talk about parenteral. That's anything other than the digestive tract. So enteral is just GI, parenteral, anything but GI at that point. This could be IM injections, sub-Q, transdermal medication patches like fentanyl patches, nicotine patches. This could be ointments or topical creams. Ampules. There's a lot of services. I try not to get ampules if I don't have to. It's a hazard, just for the fact that you can cut yourself up something fierce with an ampule if you don't break it correctly. A lot of drugs such as Epi 1-to-1 come in ampules. You can get fentanyl in ampules. The thing is, it's usually a single dose, 1 ml. You have to use a filter needle. You have to have a needle that's filtered. If not, you could potentially be drawing up glass shards. They usually have a blue line or a red line around the top of them, and that's where the glass is most weakened. Easy way, alcohol swab, place it over the top of the ampule and break it away from you. Make sure that you're covering that entirely. If not, you can cut your hand. I've cut my hand pretty bad on an ampule, to be honest, and I'm kind of gun shy of them ever since then. As opposed to a vial, which is what we're probably most familiar with. These can come in different sizes from, 1 ml all the way up to 50 mLs. Just kind of depends on the medication. You can see an example there. That's a 1 ml versus a 10 ml vial. Underneath that cap is completely sterile until you bust that seal. Once you remove that cap, it is no longer sterile. So if we're going to draw up a medication, you need to make sure that you're using an alcohol swab to clean the top of that before you draw the medication up. Some meds, we used to have like Epi that was a multi-use vial. So instead of just using it once and getting rid of it in our sharps container, you could actually use it more than once. It was resealable on its own. It would seal up on its own. I don't know a whole lot of places that carry those anymore, and I really don't know if they truly manufacture a whole lot of them anymore, but it was a thing back in the day. The problem was we saw a lot of medication errors due to, how much med they can potentially draw up, as opposed to a smaller amount. I'm probably going to be drawing up more. Mix of vials. One that I can think of right off the top of my head, and that's what this is Solumedrol. Given for respiratory issues, it's a steroid. So in the top part of this is fluid. The bottom part is powder. So to get that to constitute and literally mix, put your thumb on that top orange cap and push straight down. What you're doing is you're introducing pressure to that cork that's in the middle, that orange part. Once that pressure builds, it'll shoot that cork down into the powder. That liquid will fall into the powder and you just sit there and mix it around, like swirl it around until you don't see any chunks or anything like that. And then you can insert your syringe through the top and draw up that liquid. Pre-filled, everybody's service, I'm pretty sure carries pre-filled things such as atropine, epinephrine, lidocaine. Some places you can see on the right there, they carry adenosine pre-filled. Some places carry vials. It really just depends on what your service buys. Some stuff is pre-filled, some stuff isn't. Dextrose is pre-filled. Like I said, lidocaine. Trying to think what else. Narcan comes in a pre-filled syringe. They're super easy. Anything in yellow has to be removed. So if you look at the yellow parts on that left picture, that has to come off the needle. The yellow part has to come off the other end for the cap, and then the cap has to come off the glass vial itself. And then they literally just thread together. And then as you push it, you will see your plunger start to move to give your medication. Controlled substances for a while only came in sticks, like you see there, and we had to have a holder, like you see in the middle, to administer it. So literally that stick would screw in to that white part of that holder and would lock it into place so we could give it. You could also just use a 1cc syringe or 1 ml syringe and push the back of the stick. But the end of that stick was a lure lock. So that would literally just hook to the IV. You would push as much as you needed and then remove that stick and dispose of it. Again, that was just our controlled substances. The only times that I've seen it: fentanyl, morphine, Ativan, diazepam, and midazolam. So Ativan, Valium, and Versed. Couldn't be reused. They were single dose. Anytime we refer to intradermal, we're talking sub-Q injections, right? Sub-Q injections have to be a 45-degree angle. We kind of pinch the skin into subcutaneous tissue, inject our medication, kind of rub it around a little bit. Stomach is where we're going to see mostly insulin given. Upper arm tissue, like around the deltoid, is where we're probably going to be delivering it the most because we're going to be sitting beside the patient when it's happening. You can also do it on the front of the thigh. What you'll notice is that the locations are very similar for IM injections. IM, the only difference is we're going down into muscle at a 90-degree angle. Locations, again, I've got up on my deltoid. I've got the front of my thigh. I've got the side of my thigh. You also have your butt cheek, which is very muscular and it is a common route for an IM injection. You know, if you've ever gotten a tetanus shot, that's where they put it. The other skill we're going to be doing this week is giving IV medications. So starting an IV and giving a med, drawing it up properly, making sure it's clean, making sure it's sterile, and administering the medication correctly. Now, depending on the med, also depends on how fast I'm going to push it. Medications such as pain meds, I'm going to go a little bit slower just because I don't want to cause respiratory depression. I don't want to cause their blood pressure to drop. But if I'm giving a bolus of medication, what that means is I'm giving a set amount. I'm giving a quick amount instead of a infusion, which is a drip. Bolus is 2 milligrams versus a drip of, you know, a certain amount of fluid. Again, we're going to go through how to administer these and skills. If I need to insert medication into an IV bag, the one that is common is ketamine. You know, ketamine, if we push it very fast, we can send our patient to what we call the K-hole. It puts them into a case of excited delirium, or they start hallucinating really bad if we inject it too quickly. My service, we carry 100 ml bags of saline, small little bags. They're tiny little guys. I take my dose of ketamine. I do just what you see in that picture. I insert that ketamine into the IV bag, push it in, agitate the bag for a second, and now I have a 100 ml bag of not total ketamine. I didn't change the drug dosage. I just changed the volume. And what that does is it allows me to drip it in instead of just giving a massive one-time bolus. I didn't change how much drug I'm giving. So instead of giving 2 milligrams push, I now have to give that whole bag to get that 2 milligrams. Does that make sense? It's going to take a little bit longer, but in terms of ketamine, that's probably a good thing for our patients. And it's going to continue to give them that analgesic effect when it comes to pain meds. We're going to be going through that at Skills Lab as well. For you guys in Clinton, make sure that's brought up in your Skills Lab. I'm going to send an email about it tomorrow, but make sure injecting medications into an IV bag is brought up. Pumps, if you're doing interfacility transfers and you have to figure out drip rates, most of the time you're probably going to be having a pump. You're going to see these in the clinical settings. You're going to see these in, again, long-term transfers. I did transfers all the time to Iowa City, out-of-state transfers. They're going to use pumps. Good thing about pumps is that they are multi-channel. And what I mean by multi-channel is that picture on the left, I can have 3 different drugs going at one time, and that is going to manage how quick that it gets in. You can see that one on the left, it's giving, 15 mLs an hour. The one in the middle is 14.1 mLs an hour. The one on the far right is 3 mLs an hour. So it's managing how quickly it's giving these drugs. As opposed to me, I would have to manually titrate that with my roller clamp. I talked about I was not flowing very well. Other routes of medication that we could be familiar with, buccal administration. This is what we do with oral glucose, kind of in the cheek, in between the lower gum and the bottom lip. Intranasal meds, such as Narcan, such as fentanyl, some of our pain meds that we'll learn about. Sublingual meds, nitroglycerin. We always, whether it's a tablet or a spray, we generally give that under the tongue. Or a transdermal patch. We really don't carry any transdermal patches, but patients can have them, absolutely. And, the next 3 weeks, I believe we're doing nothing but pharmacology, if I'm not mistaken. So we're going to be doing nothing but talking about certain drugs. If you need to, again, we don't carry inhalers, but if you need to assist the patient with an inhaler, make sure that if you're going to deliver it, shake it up a whole lot. I was a kid that suffered from asthma really bad. Make sure it's shaken up. If you need to give it like a test run, what I would say is, squeeze it once to make sure that it's kind of primed. Make sure your patient is taking a very deep breath in, is inhaling through their mouth. At that point is when you want to deliver the medication, because you want it to be able to spread throughout their lungs. If that doesn't work, we have a fallback. We have nebulizers. A lot of patients are going to have their own home nebulizers for severe asthma, severe COPD. Now, you can use a nebulizer in conjunction with CPAP. You can see the bottom picture. You can technically bag in a neb treatment. I can't think of an instance that maybe if I'm assisting ventilations and I need it to open up their lungs, they have, maybe wheezing or something like that. Sure. Most of the time, people are going to be more receptive of a neb treatment if you give them that one at the top, what I call a peace pipe, instead of a mask. Because again, a mask is going to make the patient feel claustrophobic, as to where if you hand them that, they're in control of what's happening, and they're going to be a little bit more receptive to it instead of you just strapping a mask to them. We used to give ET2 meds all the time, and it was just these 4 meds. The problem with it is the dosage is like 10 times your normal dose. So it's not feasible. I mean, nobody carries that much meds. And this was really just for cardiac arrest. Lidocaine for the cardiac arrest, when it was in protocols, it's now back in. Epinephrine, atropine, Narcan, those could all be literally just sprayed down in an ET tube if the patient's intubated. Problem is, it can take like up to an hour for it to kick in. What good is that doing me? And I have to have 10 times the amount for it to work correctly. Long-term vascular devices, such as like a PICC line. If somebody's going to be getting a long-term treatment, such as an antibiotic, such as chemo, maybe they're getting regular blood draws, maybe dialysis, they can get a PICC line placed. It's going to be more of a permanent solution instead of, having to have an IV start all the time, having an IV start every week or whatever. Now, it's essentially a lock, and there's 2 different ports coming off of it. How we keep that from clotting up is we put heparin, which is a blood thinner, into the lock itself. That prevents the blood from clotting at that site. And then when we're going to give a medication, they'll literally draw the heparin out, perform their treatment, whether it be chemo, antibiotics, dialysis. Once they're done, they'll refill that lock with heparin. Again, more of a long-term thing, not something that we're going to be doing, but something you absolutely will be seeing in the clinical setting. PICC lines. You'll also see what's called ports. Now, a port is not easily identifiable by sight, but generally in the patient's upper right-hand part of their chest, near their shoulder. If the patient has a port, they'll probably tell you. Now, there's usually like 3 dots, like in the shape of a triangle, that you can actually feel, like with your thumb. Now, in the center of that is how to access that port. Most places don't have protocols on how to access a port, because you have to have a certain needle. And you can actually see in that picture in the bottom right, that's called a Huber needle. It is a specialized needle just to access ports. Personally, it has to be a very sterile procedure. I'm just going to start another IV. It's not worth having to mess with that. And, because you've got to use iodine, you've got to use sterile gloves. It's not worth it. to me. I'll just start an external IV if possible on these patients, but that is what a port is. You're going to see these in the clinical setting. You're going to see these in ICUs. Can I show you these 100%? No. And I understand that, and I wish I could. Ask questions, PICC lines, ART lines, ports. What are they? Why are we using them? Ask your nurses questions. They'd rather have you ask questions than you stand there and do nothing. Make sure you're asking questions about these things.
So, Rudy, I have a question about PICs real quick.
Yeah, go for it.
So, I know we're not allowed to access them, but
Uh-huh.
say like you have a hospital transfer and they're using someone's PIC, are we allowed to maintain them, or should that be shut down completely if they're in our care, since we can't do it?
It all depends on your protocols. Some protocols will allow for it. I worked for a place that we could access PICC lines. Or if we couldn't, and we were taking a patient from a place that we did a transfer or something like that, we would have them get us another route of access, and then they would close down the PICC line so that we didn't have to mess with it at all, because then the liability goes on them. And then they would fill it up with heparin. But some places do have, protocols that you can access a PICC line. But again, that's more of a, you'd have to have a lot more lengthy training on how to access a PICC line. But yeah, it can be done. I'm glad you asked a question about that. How the drug is absorbed and how it's really moved throughout the body is also going to be direct correlation to how it's given. You know, IV and IO is going to be the fastest routes for us to give meds. It's also going to be the fastest that our body's going to respond to it. ET tubes, if you can get it to work correctly, it says 2-3 minutes. I disagree. I hate to be that way, but you can find different curriculum that's going to say upwards an hour before you start seeing anything. Inhaled drugs are usually really quick. Albuterol, Atrovent, Duonebs. Usually not an issue. Nasal atomization, so Narcan intranasally. Sublingual, because underneath your tongue is very vasculature and it's very thin. It's a membrane in itself. Anything in our mouth is a membrane that can be absorbed. IM injections, sub-Q injections. The slowest we're going to see is that topical, like where we have either a cream. Some people will use nitro paste instead of a nitro tablet or a nitro spray. They'll use nitro paste. And it's going to take a little bit longer time. Also, if there's a patch that the patient's using for pain management or anything like that, it's going to take a lot more time before the patient can start to see an effect from it. Quickest that we're going to deal with is IO or IV. If I can't get an IV and I truly need access in that patient, I'm just turning straight to an IO at that point. All right, I know, kind of a boring PowerPoint. I wish it was more in depth than what it is. It's not. Make sure that you are looking over your chapter, especially when we, I combined this and pharmacology into a quiz, so you're probably not gonna take that for another 3 weeks, to be honest. But make sure that I'm not saying read your entire chapter, just review some of the highlights in your chapter. You can open up the first couple pages and it'll tell you terms, it'll tell you definitions. That's the stuff you should be looking at. I can't sit and read a whole chapter, but I can sit and look at key terms and kind of figure things out from there. Also look at different videos, different YouTube. I mean, there's so many different resources. Me just sitting in front of a computer, and I've said this before, isn't going to teach you everything. You guys have to venture out. You have to find what works best for you in terms of studying, in terms of retaining knowledge, in terms of getting new knowledge. And if I can help you by any means with helping, like putting you in the right direction for videos or curriculum or anything like that, I absolutely will. But you guys you got to let me know if that comes to that point. Questions about anything?
Yeah, I have a quick question.
Uh-huh.
Which chapter was it that is going over IV access?
14. It's called medication administration. I don't know why, but yeah, it's chapter 14.
Okay. All right, thank you.
If you guys have a workbook, somebody had asked me, I don't require homework to be done in the workbook. But I'll be honest, when I went to paramedic school, I had that exact workbook and I used that to study for my national registry. So that workbook does you, if you have that workbook, do it. It's going to help you out in the long run.
Rudy, I noticed that you trimmed, like the original PowerPoint was 170 slides. Are you covering other slides in lab or at other times, or did you kind of trim out stuff you didn't feel was as important?
Nope, I threw some in with farm, and then the other ones, like there was 10 slides on starting an IV. I didn't really feel that that was going to take up 10 slides when we're covering that in lab. And we're covering literally per the book way to do it. But when it was specific drug things, it doesn't make sense for me to go through it when I'm talking about IV access, when next week we're covering farm, and it makes sense if I could throw it into that PowerPoint.
So do you typically do some PowerPoints during your lab sessions?
No, I generally don't.
Okay.
Just skills.
So I got a question on the K-hole.
Yep.
Once you put them down that tunnel of the K-hole, what do you do to reverse that?
So some places will say, you know, because they're in a state of excited delirium or hallucinations. So a lot of protocols you'll have to turn to a benzo at that point, such as Versed, to either calm your patient down or sedate them because the ketamine did not work or you pushed it too fast. And there's really no reversal agent for ketamine. I mean, you can overdose somebody on ketamine technically, but there's no reversal agent for it. So usually we have to give a benzo to calm them down at that point.
If you don't do a benzo, I mean, as what's say a 170-pound guy, if you snowed him into a K-hole, I mean, is that going to take a while to come out of?
It really depends on the person's metabolism. You know, ketamine has a duration. It depends on the dosage, but you can see 10 to 15 minutes roughly before you start to see them calm down a little bit. And you got to think that 10 to 15 minutes isn't going to be them hallucinating the whole time. As the time goes on, that medication strength is going to start to die down. And when it does, you're going to start to notice a change in behavior with the patient. The good thing about ketamine is in the correct dosages, you're not going to see respiratory depression like you are with medications such as Versed. You're not going to see a drop in blood pressure like you're going to see with medications like Versed. That's why a lot of patients are using ketamine for pain management and also pre-RSI, because that's really, you know, dissociating pain from the receptor sites is what ketamine's doing at that point. But again, if we push it too fast, yeah, you can see hallucinations with the patient. They don't last forever, but using something to just calm them down, Ativan, Versed, Valium, and not a high dose of it, just enough to kind of calm down a little bit, we'll usually take care of it.
Okay, thank you.
Yep. What other questions can I answer for you guys? I know it's a lot of knowledge and I apologize. It's part of paramedic school. You guys are going to feel like you just feel totally out of your element. And I promise you, I tell every single class that. I've told the last class that don't let it freak you out. It's paramedic school. It's going to be hard. Some of this stuff will start to click when we start to do clinical and field time. And that's why you know, I can go through 170 PowerPoints for chapter 14. But when I can cover it in lab, to me, it makes more sense. When we cover IV, and it's all on the, you know, it's all scheduled. We cover IVs and IOs, stuff like that. I'd rather spend 15 minutes, 20 minutes going over how to properly do an IO versus 5 minutes talking through those extra slides, because it's a lot more pertinent for me to get your hands on the equipment than to just sit here and stare at a slideshow. I promise, if you feel lost, you're not out of the realm. That's totally normal for a new paramedic student. Second semester is a lot of the disease processes. Third semester is really easy. I always say paramedic school isn't 3 semesters, it's 2, because third semester is kind of like where you're just finishing up your clinical and field rotations. first 2 semesters are the ones that kick your butt. And I mean, you've got 2 months left of first semester already. I mean, to me, it seems like it's flying by. For you guys, you're like, God, I just want to be done with it. Hang in there. You know, you're going to have to work your butts off a little bit with studying, and paramedic school isn't easy. A lot of this stuff isn't going to come naturally, and you have to force it. You might have an aha moment, you might not. But keep on your studying. Look at different resources that might help you out. Keep doing your homework. If there's things that you're like, hey, can I get another worksheet over MedCalcs or something like that? I'll try to make another one, or I'll try to find another one online or something like that I can give you guys. I'll try to help you guys in terms of getting you whatever resources you need. I'm seeing your guys' comments in the chat about the worksheet. I was actually, as I was talking this, was deleting it because the one I put up there was for drips. So you should have it back up there in the next 5 minutes because it's in the process of uploading right now. Other than that, what other questions can I answer for you guys? And again, it's a lot of information, but if you don't have any questions for me, get out of here. Have a great rest of your night. If you do, you can hang around for a little bit, and I'll answer your questions as you have them.
Guess I got a question here, just basically based on your experience in EMS, Rudy. So my son sees a pediatrician pretty regularly because he had RSV when he was a newborn. So we have a lot of problems with asthma, and his pediatrician told me that a nebulized based albuterol is less effective than his inhaler with the spacer tube. Have you seen any efficacy to that statement?
So the reason for it is because a nebulizer, there's a lot of air that's escaping, right? There's a lot of medication that's escaping because kids are going to want to talk and want to pull the mask off. If they're using like the long corrugated one, there is medication that escapes out of it versus that metered dose inhaler that has that chamber on it. That chamber is almost like best way to put it, almost like a jet ventilation device that once you spray it, when they breathe in somewhat, it literally acts as a vacuum and sucks right down into their lungs. So you don't have that wasted medication. As opposed to a neb, you do have that medication. There's some of that medication that will get wasted into the air. And again, yeah, I'm a kid. I struggled with asthma, something fear, so I completely understand that.
Yeah, so I mean, I guess using the normal albuterol sulfate treatment in EMS, is that right? Or would it be like, wow, if we carried like a 12 dose inhaler, would that make more sense?
I don't think so. What you also have to consider is that when we're giving a neb treatment, we're also supplying it with oxygen, right? As to where at-home nebulizers are just, the ones that you just plug into the wall. You have your little medication vials, you unscrew it, put your albuterol in. So you're also not getting that higher concentration of oxygen. So in addition to opening up their lungs, we're also introducing oxygen to their lungs. And a lot of times, instead of albuterol, we're also giving Atrovent, which is the other part of a DuoNeb. It's albuterol and Atrovent. And that Atrovent acts as a steroid and also as a means to dry up secretions. So that's why a lot of times after a DuoNeb is given, you'll start to hear people cough and it'll sound really rattly, especially in kids. And that's a normal thing that we want, is because we want those secretions to dry up. We want them to be able to cough that stuff up because it's clearing up their lungs when it's happening. So in terms of EMS, I know the times that I've given it, I mean, literally, I had a friend of mine's son that he had called me. I ended up transporting him to the hospital. I mean, he was struggling so bad that I thought we were gonna have to intubate this 2-year-old in the back of the ambulance. And so I was kind of freaking out a little bit, and I was like, man, I just kept pumping neb treatment after neb treatment, and I got him to turn around just with neb treatments. So as far as what I see in the field, absolutely, I think they're absolutely great. Do I think they have their place? Yes. But if the patient has an inhaler at home and that's what they're used to using and that's what fixes it a lot of times, that's what I'm going with first. And then if it doesn't, then I'll go some other routes if need be.
just wanted your opinion. Thank you.
Okay, so I have a question. It's not related to what we learned today in class, but so I missed skills this morning.